Well, the flow seems to have calmed down, so let's get started. I'm Barry Eben, co-leader of the Wellness Committee, and we'd like to welcome you here today for a program which we have intended to allow you to be up to date on the information that's going to be useful for thoughtful self-care and for care of the community with respect to the respiratory viruses that visit us regularly and sometimes very unhappily. We also want this to be an opportunity for you to heighten your awareness of how you go about making your virus care related decisions. And so in part of the program, our speaker will be addressing some of the psychological factors involved in taking care of ourselves with respect to these viruses. One thing that you might note is that the community screens regularly have an advisory recommending masking in public spaces and meetings, and that virtually none of us do it on a regular basis, and that's very interesting, and you might even take a moment to pause and consider how is it that I'm aware, if I still am aware and haven't tuned them out completely, that messaging is there, and yet, if you're not a regular mask wearer, which most of us aren't, how is it that I end up not doing it in face of that recommendation? What's my internal process about that? I think it's worth thinking about. And you may not change your behavior, but at least to be aware of what's going on. How do I do that? What's going on? After this presentation and the question and answer period is concluded, I'm going to ask you to hang around in the room for about 5 minutes. The Wellness Committee is experimenting with a process at the end of programs. And I'll say a couple of words about that after the question and answer period and ask you to participate. Totally voluntary, of course. So it's a privilege, again, to have Dr. Christina Coulter back to update and broaden the information and presentation that she provided last fall. Dr. Coulter has a doctoral degree in behavioral science from the University of Washington. She's an advanced registered nurse practitioner and began her clinical career, if you will, about 25 years ago in Florida, working with older adults with mental health issues as a case manager in Florida. She's certified in gerontology, and she has, in fact, provided training in the past to nurses here in assisted living at Horizon House. So she is a friend and a fan of this place. Dr. Coulter divides her professional life between a now 13-year clinical practice at Swedish Medical Center in the Center for Comprehensive Care, which is the old Minor and James building, if some of you are familiar with that. And she spends part of her life professionally as a faculty member at the University of Washington School of Nursing, where she serves as Director of Curriculum Development for the Dementia and Palliative Care Program, and as lead faculty for the Excellence in Long-Term Care BSN externship. Well, the fingers aren't working too well. Bear with me. Well, this part I knew. I shouldn't have had to go to the notes. So the core reason that Christina is invited to come do this presentation here is that she was named as the person by the Swedish medical system to set up, operate, direct the COVID clinic from early 2020 to mid-2022, and she also provided clinical services in that clinic. So we actually have with us today one of our bona fide pandemic healthcare heroes. And with that, I'd like to ask you to extend a warm welcome back to Dr. Christina Coulter.
Thank you, Barry. Thank you. It's good to be back. That I was saying this always helps me kind of update all of my knowledge about the upcoming virus season for my clinical practice. And, you know, whenever I teach students, telling them about how to help long-term care communities and just their general community improve health and safety. So we're going to go through a couple different things today. We're going to review what's circulating at the moment, what's projected to circulate, what that looks like, and you know what our options are for protecting ourselves, protecting our communities in terms of vaccines. Not just about COVID, but in terms of flu and RSV and some of the other viruses that circulate on a regular basis. Then we're going to talk about prevention and risk tolerance. We'll go into all those behaviors that we all think about for prevention: masking, vaccines, hand washing, distancing, things like that. Why we do it, why we don't. We'll kind of explore some of the social psychology and personal psychology behind why we make those decisions. Then we're going to talk a little bit about long COVID. A lot of people really have concerns about long COVID, and that's well-founded. We'll talk about what it is, what it isn't, and how you can prevent it. So, all right. So, upcoming, the major viruses that are going to be circulating: COVID, also known as SARS-CoV-2, influenza A&B, comes back every single year, whether we like it or not. Other severe respiratory viruses, a big one is RSV. That one's on the rise. Many of us will catch it from the small children in our lives. And for many people, it's an annoyance, it's a bad cold, but for some people, it can be really life-threatening. Other severe respiratory viruses, some of us call them killer colds because they're so awful: metapneumovirus, adenovirus, bocavirus, and then there's the common cold that we all know so well. Bacterial infections, pneumococcal pneumonia. I'm sure many of you have talked to your providers about the pneumococcal vaccine. That helps protect against that particular kind of pneumonia. And pertussis, which is whooping cough. Many of us remember that one. You're protected from that with the Tdap or DTaP, depending on which vaccine you happen to get. Allergies are also a big thing in the fall. Trees start to shed things in the fall. Many of us can get congestion, wonder if we have a cold, wonder if we have a virus, and sometimes it could be allergies. Other environmental particulate, dust, whatnot. Nothing makes me sneeze like dust. All right. So this is a very complicated slide that means a lot and not a lot. So the circulating variants are wide. The current ones are KP1, KP2, and KP3. Those are all descended from Omicron. How many of you remember Omicron back in late 2001, early 2022, or 2021? So all of the current variants are starting really to descend from those Omicron variants. Viruses evolve constantly. They rapidly mutate and create new strains. That doesn't necessarily mean that it's a new virus. It's just a slightly different form of the same virus. So that's what's circulating right now, and all of that is to say quite a lot is circulating. All right, what does this mean? So, like we talked about, it continues to mutate, but influenza does the same thing. Many of you may or may not know that the flu vaccine we've been getting for decades is reformulated every year. We're going to do the same thing with the COVID vaccine. We're going to reformulate it based on what we think is going to be circulating and how to protect our communities at best. So is the strain important? I get this question in clinic all the time. For epidemiologists, virologists, public health officials, yes, it is. For most of us in the public and those in healthcare, it's really not. What we see is certain changes with certain things that happen. Like some variants will cause more sneezing. Other variants will cause more headaches. Some variants will cause even more kind of muscle aches. Does that change how we approach the virus? Not really. It's just a unique form. So most current strains have evolved from Omicron. The transmissibility is similar to the Omicron variant, which was heavy. That variant spreads very, very easily. So we'll talk about those, why that's important, because there are certain viruses that spread easily, certain viruses that are difficult to spread, but ways we can protect ourselves. The thing about it, though, it's highly transmissible, but if you're vaccinated, the severity is low. So that's some things to keep in mind. So COVID tracking for King County, we were above the threshold, and just recently, as of about, I think, the last week of October, we went below the transmission threshold. So that's good news. That basically means that the number of cases that come into ERs or healthcare facilities was low enough that we don't have to up our surveillance, up our attention to viral load. That's not to say that it's not going to go up again, because we're coming into cold and flu season, and that's almost always what happens. So, but King County does track this on a weekly basis still. All right, the new COVID vaccine. I get a lot of questions about the vaccine. Do I need another one? Basically, yes. That's the short answer to that question. We need a booster every year to every 6 months, depending on your risk factors. It's kind of like the flu shot. It's reformulated every year for the current circulating strains. And what that means is it's going to give you better protection and reduce the severity of any illnesses you may get. So if we think about it like a recipe book, if you get a recipe for something that is very simple, flour, water, milk, eggs, but you're not quite sure how to put it together, it's not that helpful. If we get the updated vaccine, it can tell you how to put those antibodies together for the particular strains that it's been formulated for, which gives you a better chance of mounting that response early. Two different kinds, the mRNA, I'm sure many of you have heard about that technology, and the protein subunit. They are very, very similar. Both are safe. They've been tested and tested again and tested again. They're, again, very safe. The mRNA does not change your DNA. It just helps your cells to respond to an antibody by priming them for something they've seen before. Protein subunits contain the proteins that are inactivated, that are on COVID virus units, so that your body can recognize them again and build those antibodies. So none of the vaccines cause COVID-19. They don't contain any live virus. They cannot cause infection. And they also, like I said, do not impact our DNA. They do not go into the nucleus. That being said, I hear a lot from patients over and over, well, I got sick whenever I had the vaccine. Well, you are probably going to feel a little like you're getting sick. That's your body responding. That's what the body does whenever it's building immunity. It creates inflammation, primes the immune system. Most of us feel pretty crummy. I get pretty achy, I get a headache. Most people do. It will not last very long, and you're not contagious. Again, the symptoms are normal signs. So most of us take 2 weeks after vaccination to build our immunity. So how protected are you? Well, the day after the vaccination, not very protected. So if you run into somebody who has COVID and you happen to catch it, then your protection is not up to par quite yet. It hasn't gotten up to speed. Basically, what they do is leave the body with a supply of memory for how to fight something. So, influenza vaccine, this is the CDC's latest graphic, wild to mild, and that is absolutely true. For any of you who've ever had influenza, it is pretty wild and pretty awful, but if you have the vaccine, it's not nearly as bad. So there are 3 different kinds for those 65 and older, and I would suggest getting any of the one that is available to you. Whatever you're offered, it's probably the one that you need, because we have very strict guidelines about these things. All are considered safe and effective for reducing the risk of flu. And I underline that because that's a big thing that I think is a concept I run into a lot in practice. I got the flu shot. How did I get the flu? Well, the vaccine, it doesn't create a shield. You're still going to be exposed to things. We'll talk about how to reduce your exposure risk later. You'll still be exposed. It's just how ready is your body to fight that off? How primed is it to say, I see that, I know that, I can make those antibodies quickly? RSV. How many of you have had the RSV vaccine? Yay! All right, we're doing our job. Good. So they have been increasing over the past 4 to 5 years, which was really unfortunate because as they increased, we also were dealing with COVID. RSV, for those of you who have never had it, is pretty awful no matter how old you are. It lasts a very long time, sometimes up to 3 weeks, and it causes quite a lot of chest congestion, cough, wheezing. It's definitely not fun. It's pretty exhausting. Similar to flu and COVID, a lot of people are hospitalized with RSV, and it's not something we often talk about, but I'm kind of hopeful that this will raise some awareness that it's not benign. People at the highest risk are people 75 and older, and right now we're recommending RSV vaccines for anybody 75 and older or with risk factors. If you have COPD, if you have diabetes, if you have any other health conditions, really it's a good thing to talk to your doctor about. And there are 3 available. It's a single dose. At this point, we don't have any evidence that suggests we need to boost that particular vaccine, but because we're still looking at the effectiveness and how long that lasts in the body, that may change over time. All right, a few things to keep in mind. Every human body responds to things differently. So it's a cumulative effect. Really, how many times has your body seen that virus, either through natural infection or a vaccine? How many other viruses have you contracted over your lifetime that were similar? So all those things prime your immune system to respond. On the other side, some of us have lungs that just are not as robust. Some of us have sinuses that are really problematic. Those things also play into what your experience of a particular virus will be. So I might contract a virus, and with my unique health issues and conditions and risk factors and exposures, I might have a very different response than somebody who's otherwise my same age and health who hasn't had the same exposures, experiences, and health conditions. So your neighbor might get the exact same strain and be just fine. They might have the sniffles, and you might be laid out for a week. So it's variable is the point. And it's not always going to fit the typical symptoms. One of the things I hear often in clinical practice is, people will come in and say, well, I could have sworn it was allergies. I just had a runny nose and, some sneezing. I can't believe I tested positive for COVID. So things can mimic other things. And one of the point of that is we always should test. We should always be seen or checked or consider other possibilities. Because the last thing we want to do is spread COVID to everybody. Again, vaccines are intended to prime the immune system. They cannot prevent an exposure. I feel like I say this almost daily these days. It's not a shield. We're not walking around in bubbles. It's just helping your body fight it off more effectively. They do dramatically reduce the risk of complications. I am sure that many of you were concerned in the beginning because the severity and the consequences for catching COVID in, say, April of 2020 were severe. They were almost certainly going to land you in the hospital and potentially with some long-lasting complications. Now that we have vaccinations, most of us don't think that that's a risk. It actually still is, but with vaccination, our risk of those complications is much less. Prevention. A big, big part of what we're going to talk about today is prevention, because that's an ounce of prevention is worth a pound of cure. I've heard that my whole life, and I still repeat it almost every day. Staying up to date with immunizations is probably your best way to protect yourself and reduce your risk. It's much, much easier to stay in your home for about 5 to 7 days, read your favorite book, and drink some tea than it is to end up in the hospital. So stay up to date with immunizations, please. Good hygiene. So I'm not just talking about, how clean your clothes are, but good hand hygiene. When we touch high-touch surfaces, many of us are face touchers, whether we realize it or not. I do it all the time. I had to learn how not to during the pandemic. During the height of the pandemic, I realized that was going to be one of my biggest challenges. Thankfully, with all the PPE I had to wear, my face wasn't even touchable. But many of us do touch our faces. We scratch our eye, we itch our nose, without even really thinking about it. If you've just touched an elevator button and then you scratch your nose, it's potential that you have just picked up whoever last touched that button and the 12 people before them. So it's something to consider. So lots of, hand sanitizing, hand washing, things like that. Masking, very controversial, has been from the beginning. It is still the single best way to reduce your exposure risk. So the likelihood that you're going to pick up COVID from somebody breathing it into the air is much, much improved if you're wearing a mask. And we're going to talk a little bit about why we wear masks for ourselves and why we wear masks for other people and how that plays into the decisions we make. Physical distancing. Most of us don't do this anymore, but it does still work. So I'll bring this point up again, but even Anthony Fauci, who's now 83, says that he practices strategic masking and distancing. If he's in a widespread open outside area, he tends not to wear a mask. If he's in a crowded, contained area with not as much ventilation, he's wearing a mask. So something to think about. The other thing to think about is when you are sick. Testing is still really important. I find a lot of people don't test anymore. They think it can't be COVID. I'm not severely ill. It very much can be COVID for any of us. So testing, especially on that first or second day of your illness before you've gone back out or gone into an area that's public, is important. It helps to reduce the risk to others. Precautions to prevent spread. If you must go out, wearing a mask. That's going to help reduce the amount of virus that you breathe into the air and will dramatically reduce the risk to others. Seeking health care. I will be the first to admit and acknowledge that getting into one of us is incredibly hard right now. How many of you have experienced that? Yeah. We're working on it, I promise. But it is hard. So Washington State still has a virtual care service where you can meet with a provider and discuss your options. I hear that's going away if it hasn't already. So that's not great given the upcoming virus season. However, there are other options, and often if you call your primary care doctor's office, they can direct you to an option or an alternative. So then the next question, the $1 million question, Why do some people do all, some, or none of these things? Why do we do what we do in general? How do we make the decisions we make? And why does one reasonable person make a different choice than another reasonable person? Risk tolerance. So that's one factor. We're going to talk about many, but that's one factor. So the degree of uncertainty or risk that is acceptable in or for a given situation. How much risk are you willing to tolerate? So the first picture is somebody climbing a mountain. Second picture is somebody rock climbing. Both of those pictures are me. So, and I do that because risk tolerance is very personal. So areas of my life where I'm able to accept certain risk, I won't accept in other ways. And I've had this conversation with many people over my time. I'm willing to do that. Granted, there is a rope, so this is not free solo. I'm willing to do that, but I'm very conservative when it comes to my financial decisions. I do not like to accept risk when it comes to financial decisions. Likewise, in terms of virus exposure, I wear a mask at work 100% of the time. I'm in a healthcare area, I'm always wearing a mask. And I typically, if I'm in a crowded area or if I'm in an area where there are people at risk, I would be wearing a mask. If any of you were standing more than 6 feet or less than 6 feet in front of me, I would have a mask on. So that's kind of risk tolerance wise, that's how we think about things and how we make the decisions we make. So what influences that? Well, our estimation of our capability or our experience. So in terms of experience, I've climbed mountains, I've rock climbed for a long time. I know what my experience is. I know what I can and can't do. And definitely I don't do certain things because I'm pretty sure it would not end well. But my experience with those things is what leads me to make those decisions. Likewise, any patient, any person thinks about what's your experience with an illness. What was your experience the last time you had a cold, a flu, COVID? How did it feel? That influences how much we consider what we do next time, whether or not we wear a mask. Familiarity with the subject. How much do you know about COVID? Did you know somebody who potentially lost their life during the beginning part of the pandemic? That's part of your experience and what the risk is. Understanding the recognition of consequences. Many of us don't realize that we can still end up in the hospital. And a sense of control. There's a whole field of study about our internal locus of control or external locus of control. So our ability to control the situation by taking action. Personal risk tolerance influences most behaviors, financial, leisure, relationships, and health and safety. So what else? Well, there are a lot of theories that go into it, and I will not read you this slide because I hate it when people do that. But protection motivation theory says that our motivation to engage in protective behaviors is influenced by our perception of the threat and also our personal coping. Am I able to enact the thing that I need to do to protect myself? Wear a mask, get a vaccine, use hand sanitizer. But it doesn't account for the social and environmental factors that go into it. The theory of interpersonal behavior says that our behavior is influenced by the people around us. Are they all wearing masks? Are they all getting their vaccine? Is it a social norm? So lots of other theories play in, but all of that is to say that all of our decision making is a really complex interplay between what we personally believe, how we feel about ourselves, and what everyone around us is doing, and what they perceive and how they behave in terms of what is right and wrong. So to mask or not to mask. As Barry said, lots of different places there are signs to mask. Whether or not we do or not is an interesting study. Because at work, I have many colleagues who are very well-respected physicians, very knowledgeable. They've been mentors to me. They don't mask. So lots of things go into it. So our personal beliefs, our perception of the efficacy, or is it effective? Our ability to change our own behavior. I will be the first to say that my ability to change my own behavior is a long curve. Takes me a while, but I can do it. Our emotional response to the situation. And conscientiousness, our perceived threat. That's a big one. Many people don't believe that COVID can impact them in such a negative way until it does, or they watch it happen to somebody else. And even when they watch it happen to somebody else, they might think, well, it won't be that bad for me. It very well could be. Familiarity with the person. That's the biggest one I've seen the entire pandemic. Well, they were my family. I know them. They're good people. Good people get COVID all the time. So, social beliefs. Prevalence of the behavior. It's self-reinforcing. I see somebody else wearing a mask. I wear a mask. It's the social norm. Okay, I'll wear a mask. Social identity. What's your role in that community? Are you a leader of the community? Are you wanting to be accepted? Those are big factors that play into whether or not we choose to engage in a protective behavior. The concept of the social norm, what, quote unquote, most people do versus what is the right thing to do. Are we doing things based on what everybody else is doing, or are we doing things based on what we think is the right thing to do? Perception of the social contract, that's a big one. And the threat of the threat to the community. So how much do I think I might be a threat to the community if I'm not wearing a mask? Well, in my case, I work in healthcare. And early in the pandemic, I'll be honest, I didn't see anybody unless they were 10 feet away outside, because I was seeing patients with COVID every day. And I lived alone at the time, and I wasn't going to infect my plants. So I was feeling like I was doing all right. All right. So our choices and behavior are influenced by our communities. So again, we've kind of talked about this ad nauseum, but studies do show that our perception of what is the social norm, what's the right thing to do, are some of the most impactful influences on whether or not we choose to mask, get a vaccine, do hand hygiene, things like that. So there's a Swiss cheese model. I won't go into detail about this, but basically every single thing you do could block a potential exposure. So if we layer those by wearing a mask, maintaining some distance, getting vaccinated, washing our hands, those all create more barriers as we go through. So we're going to talk a little bit about long COVID. How much time do I have left, Barry? It is 35 after. Okay. 10 minutes. Great. Thank you. All right. So what is long COVID? How many of you are worried about long COVID? Okay. So we're going to talk about that. So it's a syndrome of symptoms that persist longer than 3 months. I hear all the time, well, COVID is only supposed to last a week. Absolutely not. That is false. COVID can last up to 6 weeks, 8 weeks. It just depends. I've had people who really struggled with the last part to get over, and that's the fatigue. That is not long COVID. That's just lingering acute COVID. The fatigue takes most people 6 to 8 weeks to get over, including athletes. People who are more athletic than myself, I've seen them laid low for 8 weeks. So that is not long COVID. Long COVID is when it persists longer than 3 months. Yeah, it takes a lot of us a long time to get over. So it can be any number of symptoms. Extreme fatigue is the most popular, the most common that people report. Mood changes, cognitive changes. That's a huge one. Feeling depressed, feeling anxious. I'm more distressed than I normally am, or I'm having more trouble thinking. That's common. Shortness of breath and air hunger, that one is less so now that most of us have been vaccinated. We're going to talk about how vaccine impacts your risk of long COVID in just a minute. There's a concept called dysautonomia, and it's where you stand up and you get lightheaded. How many of you have ever had that, ever in your life? Yep, me too. That typically happens when we're dehydrated, our blood pressure's a little low, maybe our glucose is a little low, we haven't eaten, but imagine if it happened all the time. That's dysautonomia. Lightheadedness, palpitations, those things. Neuropathy. So we can get that numbness and tingling that many people with diabetes or just some lumbar back pain have. A little bit of like tingling or nerve pain in your feet or hands, and vasculopathy. There's a lot of coagulation problems that can occur with COVID, and if they persist into long COVID, it's a problem. All right, what causes it? We really don't know. We still don't know, is the bottom line. There is ongoing research all the time. Lots of people are working on it, but at this point, we really are unsure. So there are theories, persisting viral circulation, that create recurrent reactivation of the virus. It also may be inflammatory cytokines from the virus itself. COVID or SARS-CoV-2 impacts the endothelium of the tissue, and we have that in most of the systems in our body, and so it creates a lot of inflammation. It also can cause a dysfunction of the immune system. So I think every single one of us in this room is old enough to have had chickenpox. The younger kids got a vaccine, lucky them. But most of us have chickenpox, the virus that causes chickenpox, still living in our body. Our immune system is constantly suppressing it, keeping it at bay. If we get shingles, that's the reactivation of that virus. We have other viruses that are like that. Epstein-Barr, some of us have cytomegalovirus. Our immune system has worked to suppress those viruses since the time we got them. If it gets distracted by COVID, maybe that reactivates. That's another theory. So those are some of the predominant theories at the moment. Who's at risk? So anybody who's not vaccinated. The risk dropped from 10% of people who got COVID to 3% of people who are up to date with the boosters. That's not, did you get your primary series? It's, are you up to date with the booster? That dramatically reduces your risk of developing long COVID or PACS. All right, people with type 2 diabetes, any autoimmune diseases, if your immune system and your inflammatory system doesn't function well anyway, or has a little couple of quirks, that does increase your risk. So it's something to think about. And morbid obesity does increase your risk as well. We used to think that people who had a very severe case of COVID or were hospitalized were at a higher risk, and that still is the prevailing theory, though there is some evidence to say that that might not be the case, especially now that many of us are vaccinated and we're not ending up in the hospital. And multiple COVID infections. So I want to highlight that as much as possible. Multiple COVID infections. Each infection you get can increase your risk of developing long COVID. So there's a lot of sentiment out there I've heard from patients. Well, I already got COVID. It was fine. I'm fine. It'll be fine. Second and third time, they're not fine. So it is something to consider. Preventing it. So avoid infection. That's the biggest way you can prevent it. Avoid infection. And that means coming back to boosters every year or every 6 months, depending upon your risk category, wearing a mask, good hand hygiene, and trying to avoid infection. You know, the other thing I hear a lot is, well, I went to go check on my friend, she was sick. Well, she had COVID. That was a very nice thing to do, but now you have COVID. There are lots of other ways to support somebody who's sick. We can leave things at the door. We can both wear a mask, so on and so forth. Allow yourself plenty of rest if you do get COVID. Drink lots of fluids and talk about treatment options. The other big question that comes up a lot is, will Paxlovid prevent long COVID? There is some emerging evidence that it can. So if you get sick with COVID, please call your provider. Please call and ask about COVID, or ask about Paxlovid if you're a candidate for it, because it can reduce your risk of those long-lasting complications. And that will be it. Questions? that one not working?
I'll try.
Just how effective is masking?
So I'm going to go back and I'm going to show you that diagram. Thank you for that question. So you see the amount of this is a real CDC picture. So the amount of, obviously it's a cartoonized version, but the amount of virus that's being shed by somebody who's unmasked is pretty significant. If that person's masked to the other person, very little. The risk of transmission, even in the beginning when none of us were vaccinated, but both people were wearing masks, it reduced the spread of the virus and it reduced risk of transmission by over 80%. It's most effective if the person who has the virus is wearing a mask, but even if I'm the only one wearing a mask, I'm still protected. Case in point, I have sat in an exam room. I know you've all seen an exam room. I've sat in an exam room, they're not big, they're small, with a patient who was unmasked, and then later texted in, wrote a MyChart message, uh-oh, I have COVID. And I did not catch COVID. That has happened repeatedly. You can protect yourself by wearing a mask, even if the other person is not. So it's very effective. If both people are, it's significant.
Lynn had a question over there.
So the question has to do with hearsay.
Okay.
I've been told that you shouldn't get an updated COVID shot if within 2 months if you've had COVID. Now, the question is, I got COVID in France, and I didn't know I had COVID because I had a running nose. And when I got home and realized that my allergy medication wasn't working, I tested, and of course I was positive, as did my colleague, and then 9 other people in a 19-hour group.
Yep.
But so should I, this was in July, so do I wait 2 months, 3 months, or don't wait?
So what I usually tell people is waiting 2 to 3 months is the appropriate thing to do. It's not because it's going to hurt you. It's because we want to get the most protection we can from your natural infection and the booster. So for example, you have some natural protection after that infection for about 2 to 3 months. That's the evidence we have that our natural immunity lasts about that long. So then we get the booster at 2 to 3 months, and then we get protection from that for 6.
Is there any difference between the COVID that's rotating in Europe versus U.S.?
The slide that showed all the variants, it's very similar in Europe. So any one of those variants could be the variant you caught because they're all circulating everywhere. Yeah.
Thank you.
You're welcome.
When should you test? And what to do if you do not have a test?
So when should you test? When you get symptoms, you should test. Whenever I had the last cold I had, which was not COVID, I tested on day 1. When I knew I had symptoms, I tested. And then I stayed home from work. I did virtual visits because I like to work. Did virtual visits, and 2 days later I tested again to make sure it was accurate, and it was negative. If you don't have a test, what I usually suggest is ordering them as soon as possible, or having someone bring you one and leave it at the door. Yeah. But I usually test on day 1 and 48 hours later. So the older tests, if they are expired more than about 2 to 3 months, they probably are not as effective, and I would not trust them.
Oh, that list that you had about influences whether or not you wear a mask. Masking, I don't wear a mask sometimes when I should, like now, because it does influence my behavior. I'm slightly hard of hearing. Many of us in this age group are.
Yes.
More or less. And I cannot understand someone who's talking through a mask. And I don't want to be impolite, so I nod up and down as if I'm understanding. Oh, yes, yes. And I don't. And I just try to terminate the interaction as quickly as possible because I'm so uncomfortable that I may be missing something I shouldn't. So that is the main reason I back off from masking, is that it does influence my behavior.
Yeah. And thank
Negatively.
You for, yes, and thank you for bringing that up. That is a huge factor for many people who have hearing loss. Because whenever I try to speak to someone who has hearing loss, I have a good friend who's, without her hearing aid, she's legally deaf. She reads my lips most of the time and puts those two together. So it is a really, really tricky thing. I agree.
Along the same lines, you see people wearing the shield as opposed to the mask, either up or down. In Japan, you'll see the kind of upside. Does that make any protection less or more?
So it does. Believe it or not, it provides more protection for the person wearing it versus the person not wearing anything. So, which is kind of the opposite of a mask. The people wearing the mask are actually protecting the people they're talking to more. They do provide some protection on both sides, because anything that creates a barrier between the aerosolized particulate that is coming out when anybody speaks or breathes is protection. Is it as much as a surgical mask? No, because it's still coming into the air. The longer you're in that space with that person, the more potential exposure you'll have. But it does provide some protection. And during the pandemic, for what it's worth, when our PPE was very limited, before I had what's called a PAPR, which makes me look like a spaceman, I wore a face shield and a mask. And that's how I was able to do that. Yep.
I'm not, oh, good. What is the relative safety between masks? I have everything from N95s down to these flimsy things. I always wear, or try to always wear, some mask.
Yeah.
What's the relative difference of protection
So
for both me and to others?
And to others. So with a surgical mask, you're mostly protecting other people. You're getting some protection yourself, but not as much. But you're actually protecting everyone else quite well. With an N95, you're protecting both ways. It is the best protection either of you can have. Okay, and then over there.
So once you're diagnosed with long COVID, what's the prognosis? I mean, are there remedies? What's the hope?
Well, so there is hope. I have lots of people that I saw for long COVID who are now what they consider recovered. The thing about it is it's subjective. So what one person considers recovered may not be recovered for somebody else. What treatments do we have? It's all based on symptoms. So depending on the symptoms someone tells me I have a variety of medications that we can use, that we use for other things that impact that system. There is no FDA or approved treatment for long COVID per se. So it's kind of a trial and error, as we would say, and a management of symptoms. Yeah.
Is this on?
Yes.
First, thank you very much for your thorough, thought-provoking teaching us more about virus. My question, you mentioned post-acute COVID syndrome.
Yes.
And within that, or PACS, P-A-C-S, there was one element about nerves.
Yes.
Can you go back and
I
tell
can.
us more about that?
I can. Okay. Neuropathy.
Neuropathy, that's
Yes.
the word, yes. How does it vary? How long would it persist? And is it related to carpal tunnel?
So anything that injures a nerve or upsets a nerve can cause neuropathy. So in the case of carpal tunnel, it's usually that space, that the nerve travels through gets impinged, makes the nerve angry, and it fires off more. So that's carpal tunnel. In the case of post-acute COVID syndrome, most often the entire nervous system, including the peripheral nerves, are irritated. And it's more a systemic versus an impingement by an outside body, like a bone. And we're not exactly sure why it happens, other than it creates a hyperexcitability and almost a misfunction or a dysfunction of the nerves and their sensation. So our nerves give us sensation all throughout our body. If I poke myself, that's my nerves telling me you're poking yourself. If my lumbar spine is starting to collapse and it's hitting those nerves, I'm getting that numbness, tingling, kind of achy feeling in my toes or in my leg. With COVID, with long COVID, we're not exactly sure why the nerves get angry and irritated. But one of the worst cases of long COVID that I have seen, this particular patient had numbness and tingling that was constant, and kind of that burning pain that some of you may know from nerve pain in their hands and feet, and we have yet to figure out how to fix it. So.
What can you do? What can you do about it, or what should you do about it?
We have some medications that we use for nerve pain. Some of you may be familiar with gabapentin. That's one of the ones we use, and sometimes it's effective and sometimes it's not.
Thank you.
You're welcome.
Christina, over here.
Question, I read that we should not get our COVID test yet since it only lasts for, I'm going to throw out 3 months, because the heavy part of COVID will be in the middle of the winter.
So you said COVID test. Did you mean vaccine?
I did. I'm sorry.
Okay, that's okay. I just wanted to make sure.
Yeah.
So at this point, we are coming off of a major surge. The surge of COVID that we had this past summer was the highest we've had since Omicron, January of 2022. So that's not to say that it's going away. The effectiveness of vaccines lasts approximately 6 months. And my recommendation for most everyone I see is get your COVID vaccine 6 months after your last one, or 3 months after your last infection.
And the flu shot.
And the flu shot. And your RSV, but not all at the same time, please. You will curse my name. Yes.
Is it possible to have not had COVID?
It is. Oh. It is. Yeah. Every great once in a while I hear of somebody who hasn't had it yet. So.
Another question.
Yes.
Does King County monitor wastewater treatment?
We did at one point. I believe that program was suspended.
Another question.
Yep.
You said we shouldn't get the shots together. Which one should we, and which one should we not?
So I just don't want anybody to get all three together. So you can get 2 of them together and then get another one 2 weeks later. It does not matter which ones you get together. The difference is if you were to get all 3 together, your immune system has a lot of work to do. I typically don't give my students 3 term papers at the same time. So let's give your immune system a little bit of a break and let it work on just 2 things at once, and then get the next one when it's ready.
Okay.
All right. Thank you, everybody. I really appreciate the attention.